Yeah, that's it now.
Thank you so much for this presentation. Next in the program is Finn McCarthy is here from EUPATI, another international organization. Finn, thanks so much for joining. You'd like to take the floor here?
Yep.
Okay.
So hopefully the slides will work as well. And while the slides are coming up, I'll just quickly explain who I am. So my name is Finn McCartney, and I am in the projects and grants team at EUPATI. It's the European Patients Academy on Therapeutic Innovation. And our slogan is empowering patient involvement through education. We believe that patients can only get really involved in things like health technology assessments or when it comes to clinical trials if they understand the science and it's explained in lay language or patient-friendly language. A quick history of how we started. We started back in 2012 as an IMI project, and as of 2020, we are now our own NGO and non-profit based in the Netherlands. The two pillars that I'll talk about mainly is our information and education, and we believe that our mission is to inform, educate, and I can only do this through collaboration through multiple stakeholders. This is the patients, these are the health companies, and also academia as well. And all the resources that I'm going to talk about have been co-created in this multi-stakeholder approach with patients at the center of this. The first one I want to talk about is the Toolbox. It's an online catalogue of all medical research and development jargon. So things like what is AI, what is a clinical trial, what is a biobank, these very common questions which people in this room may understand and know off the top of their head. But as someone who is a layperson like myself who only did GCSE biology, my understanding is very limited. We recently published an article on real-world evidence and real-world data. It's about 12 pages long, but we did this with input from our industry clusters, our academic clusters, and we also had our EUPATI fellows, who are patient experts, go for this 12-page article and say, this is correct, this might be too technical, and as someone whose first language isn't English, is Greek, this may be how you want to tweak it or add some more additional sentences so that anyone can understand it. And the highlight is that it's 8.2 million users have used this platform today. It's available in 14 languages, and it's non-disease specific. So if you're a diabetes patient or you're someone who has cancer, the information is there for you to take, adapt to your situation, and then hopefully use it in your patient advocacy journey. The second thing I would like to talk about is the Open Classroom, more specifically the Patient Expert Training Program. So it's an open classroom, it's free, it's online, and it's on demand. There's no need to sign up unless you want to be certified in the unit that you are taking. So this is anything from a clinical trial, what is it, what is a protocol, all the way down to what is a health technology assessment. So when do patients get involved, what is the responsibilities of a HTA body, what's happening at the EU, and how does that actually relate to my national platform as well. It's all well and good saying that, people access these materials, but where do these people actually come from, and are they coming year on year? And I'm glad to say that they do. To date, we're at about cohort 8, so we've been doing this program for 8 years now, of which we have about 415 EUPATI fellows. These are individuals who have gone through the entirety of the medicine's research development cycle and seen where patients can be involved. And if I remember from where people are coming in this room as well, they are also supported by their national platforms as well. They are self-governing entities who collaborate with EUPATI and also translate those materials into their local context. So I think there was people from Spain, there's people from Sweden as well, and they're a very active national platform. And they also have their national training programs as well, contextualizing the materials that we have at the international level into what's actually happening in the Swedish system as well. And this is just a breakdown of where these individuals come from in terms of disease areas. We do see a big area coming from cancer and rare diseases. However, as you can see, it's not just, they are the only ones coming, it's from other areas as well. And this is not only limited to the patient themselves, this is caregivers who also want to understand more as well. The impact of taking this course or doing anything like this can be seen from here. It's a leadership role in a patient organisation. You see that people who didn't know much actually take more of a leadership role and want to build up their patient community. When it comes to advising pharmaceutical companies as well, there's an increase of 34%, which I think is brilliant. if you understand the jargon and you can have that conversation with the scientific officer or someone from pharmaceutical, you feel more comfortable and you can contribute. And finally, it's when it comes to a regulatory agency or a HTA body. A quick highlight, which is the project which I'm still currently leading, called HTA for Patients, focuses on getting the EU HTA regulation and training up patient communities for the joint scientific consultations and joint clinical assessments, which are being done at the European level. So the acronyms such as what is a JCA, JSC, PICO, what is the conflict of interest, all that information is freely available on our platform, and those who have gone through this training process and this course and these online training sessions will be called upon in order to provide their input for a given health technology assessment. This is what's happening in the EU, and I know it doesn't really apply to what's happening in the UK. However, we do have 5 other courses which give the basic principles of HTA more generally as well. And this kind of summarizes EU PATI in numbers. 8.2 million people have access to our course, and it's available in 14 languages. Those who are connected to EU PATI is about 415 patient advocates, and they are supported by their national platforms. And I'm glad to say that we do have one in Scotland, but I am looking for the English and the Welsh one coming hopefully very, very soon. If you would like to find out more about EU PATI or scan the QR code to find about the Open Classroom, feel free to do so. And before I pass it on to the next speaker, I would like to highlight a new project that we started back in May, which is all about generating real-world evidence and real-world data guidelines. It's the 5-year project which has been co-funded by the IHI, and the idea is that you will produce new guidance on what real-world evidence and real-world data is. We'll have lay summaries on the case studies chosen for HTA, not just on medical devices, but health, therapeutic innovation as well. And this also happens for regulatory market access as well. And on top of this, there'll be a new course on what on earth health data is and how does it actually work in the healthcare system. So there's questions about how can I trust that my GP is taking my data and using it efficiently, what is a biobank and how is it stored ethically. All these case questions will be answered hopefully in this course, and even though it's a 5-year project, I expect this course to be up on our Open Classroom, freely available by about 2028. So thank you for your time.
Thank you so much, Finn, for this presentation. Next speaker in this session is Mirana Randriambelonoro. She's the Chief Technology Officer of GD Hub. It's an interesting organization that we partner for the Data First AI Later movement. From science to policy, the role of a global collaboration platform in digital health. I hope I got it the right one title, Mirana, because you changed it, right? This is the one, right?
Yes, this is the one.
The floor is all yours.
Thank you. Can you see my screen?
Your screen is live here.
Okay, good. Good. So, hello everyone. So it's really a pleasure for me to represent the Geneva Digital Health Hub today and to share our work on how we support digital health implementation, decision making, and policy making. So our goal at the GD Hub is really to connect the dots by linking digital health knowledge, people, and policy for scale. The GD Hub was co-founded in 2021 by the University of Geneva and the Swiss Agency for Development and Cooperation, and it really comes from 20 plus years of implementing digital health in LMICs and also in high-income countries. So we have implemented a lot of different types of solutions. We have faced failures and successes, and we believe that sharing these failures and successes is really important to inform future implementers, because we saw that even though the technology has evolved, the challenge remained the same. It's about non-interoperability, the challenge in the processes, in patient adoption, healthcare professional adoption, and so on. So it's not really about the technology itself. So the GD Hub support implementers, innovator, and decision maker in different areas. So by science, by delivering actionable science-based insight, by providing different type of tools which help with data analytics and knowledge management tool. I will present one of them later. We also support communities, so we build and support communities of practice. We have different communities of practice that we are following right now to foster collaboration among the different stakeholders. And then we also do implementation and try to bring really scientific evidence from this implementation and build the bridge between this implementation and policy to create long-term changes. But today I'm going to focus on one of our tools, our knowledge management tool, and to show you how we are trying to support decision-making and policy-making via this tool. As we all know, digital health holds great promises, and around the world, there are valuable digital health projects that are transforming healthcare. But too often, these efforts work in silos, struggle to scale, and valuable lessons are lost. There is no shortage of information, but unfortunately, we are joining in it and not learning from it. So what if there was a better way to capture, organize, analyze, and extract insight from all this knowledge? What if we could make this information more digestible, actionable, and science-based to guide smarter decision-making? This is what we are trying to do with the tool that we call Implementum to turn real-world digital health implementation data into insightful science-based information that support better policy and implementation decision. But Implementum is not just a tool, it's really a consortium of partners dedicated to making digital health implementation knowledge a public good by co-creating with the community and by supporting the science-informed decision-making. So with these different partners, we have developed a set of toolboxes to capture knowledge from both implemented projects and scientific research. One of them is the Digital Health Atlas. So it was initially built by WHO. It's a repository of digital health projects, but we have integrated it in the platform and improved the data structure to make it easier to navigate through the data and to connect the data together. Then we have tools that help communities to exchange and share their experiences. We have the AI assistant that I will show you briefly later as well. And one that was recently launched is the evidence gap map in collaboration with Johns Hopkins University. It's a special evidence gap map on maternal and child health to show where we are missing, where there is the gap still in evidence related to digital health intervention and the impact on health outcome for maternal and child health. And then the assessment framework that we do in collaboration with ICRC. But today I'm gonna show you a closer look of the Digital Health Atlas. So there are several ways to explore the data depending on what you are looking for. You can navigate the interactive map and focus on a specific region. For example, if you are interested in a specific region, you can use the search function to find topics or keywords of interest. And then you can also apply, if you want, different filters to narrow down the result. For example, if I want to see all the projects, let's say in India, that use diagnostic as services and focus on maternal and child health, I can really specify what I'm looking for and get a more focused result. In addition, because high-quality data is essential for informed decision-making, we've introduced a data curation process, and this highlights curated projects that meet specific quality criteria, such as having recent updates, providing key information, such as lessons learned, insight, business model, and more. So the curated projects are easily findable through the platform. When you open a specific project page, you'll find the key element, such as general information related to the project, details related to the implementation, economic and financial aspect, insight and lessons learned, one of the most important information that we are capturing, and then the source of data, because we want to really be transparent about where is the data coming from, as well as suggestion or similar and related project if you are interested to explore more. And the platform is now available in 8 different languages. However, having information is not enough. So to transform data into knowledge, we've developed a digital health AI assistant, which is a conversational interface that helps users interact seamlessly with the data. So for example, concretely, as a policymaker, I can understand the digital health landscape in my country at a glance. Here, for example, I'm asking about Senegal, what projects have been implemented in Senegal. Then the assistant give me a synthesized answer about the different projects. I can also go more deeper. For example, if I want to ask a specific question, let's say related to decision support project in West Africa, for example, I can ask the question and really ask the assistant to give me like comparison about specific variables or component of the project. For example, I want to understand the difference in terms of target population, in terms of context, in terms of lessons learned that have been shared by the project. So it really helps to navigate better with the data that we have in the database, and all the information are based on the project information that we have in the database. So the data are coming from different sources. So it can come from the project stakeholder itself. And this was really a paradigm shift, because we want the project stakeholder that knows best about the project to share their experience and the information related to the project. And we are also getting the data from the different communities of practice. We have communities of practice on telehealth, on space and global health, and on clinical decision support. And we have different partnerships, for example, with WHO. We partnered with them for the Digital Health Atlas. We are also partnering with Pierre Fabre Foundation for their ODS platform that collect as well digital health project. In conclusion, what I can say is that quality data is key. Our goal is not only to provide a registry, but really to provide context-aware insight by country, by topic, or by funder, to support evidence-informed policymaking, to leverage on the real implementation data, so the project data and existing guidelines, and to guide future implementers step by step and advance the science of implementation. But as you may guess, we cannot do it alone. This is a collective effort, and we need your experiences, your insights, your project. So join us, add and update your project, mobilize your national ecosystem, and let's coordinate for a better digital health impact. Thank you.
Thank you, Mirana, for bringing this interesting platform. And last but not least, we have the Catherine Kronaki, Secretary General of HL7 Europe, and is going to talk about policy and interoperability frameworks to scale empowerment and collaboration. Catherine, the floor is yours.
Give me 1 second to show the slides. Yep, it's there. So I think it looks good, no? You can hear me well?
Perfect.
Yes,
All right.
We can hear you fine.
Hello, everyone. It's a great pleasure to be with you, even remotely, and listen to exciting talks. In my lightning talk, I will try to give you a different perspective a little bit from the European Union. I mixed up two different titles that Paul gave me, governance and interoperability from policy to practice, frameworks that scale empowerment and collaboration. And my message is clear. All right, we want this. How do we scale? How do we implement? And I will focus as an example to the European health data space, but of course this can be transferred. So a little bit about HL7. HL7 has been around for more than 39 years now, with the vision that everyone can securely access and use the right health data when and where needed. We were born, the European office, at least in 2010. And since then, we are very active in the European policy space with the activities that relate to European funded research, with collaboration with 22 affiliates, including the one in the UK. And also we have created two initiatives, the Hospitals on Fire initiative, which explores the maturity of hospitals and healthcare facilities to implement the FIRE, our API-based standard, but also the Phoenix initiative, which looks at the cancer model for Europe. Last but not least is the International Patient Summary, which is something we had long and strong involvement. But let me move gears now and explain to you my favorite picture of the HealthDS. And this fits very well with the previous speakers. So this slide is a slide of the European Union, of the European Commission, that has been adopted by myself and actually shows what the HealthDS does for me and you. It gives us several rights of natural persons. There is the assumption that there is an electronic health record system or health data access service where you can access your health data and you can download a copy of your data, but not a copy like an image or a PDF, an actual computable copy in the European health electronic health record exchange format. You can also get from your devices or wellness apps, you can actually share data, insert data into the electronic health record. And last but not least, you can also provide a copy of your data to another app. So these are all very exciting. And I didn't mention even that you can appoint an authorized person to access your data. You can prohibit data to be accessed by somebody. You can request a rectification of your data, and you can set access restrictions, including saying that you don't want digital. So what do? We are a project called XR, which says, okay, so the eHealthDS mentions 6 types of data. Can we extend? How? So we developed the notion and the vision of the XR button, which is about clicking in any patient-facing app or website and getting your data in the European XR7 FIRE format, which is called EHRXF for European Electronic Health Record Exchange format at the click of a button. Now the regulations talks about laboratory, hospital discharge report, patient summaries, imaging reports, e-prescription dispensation. We want to extend it to IPS Plus, which is a patient summary for research and public health. So we create a bridge between primary use of data and secondary use of data, and also care plans. And this can be some of the existing priority data categories or new ones. The important other thing we say is that you can download your data by clicking on a button. You can share your data with a QR code, or you can do what we do sometimes with our friends on Facebook, share our location. Here, for a period of time, you can share your data. All right. And how do you do that? What is the format? We are working with HL7 fire specifications because there is a decision that the European Electronic Health Record Exchange format will be based on fire, and there is already an implementation guide for the button, which was used in the latest IAT Connectathon and delivered 14 labels. But what I would like to mention, and what I'm really excited, is a paper that we wrote, and that's the part about from governance to practice that I would like to bring to your attention and maybe get some of your insight. So the publication of the FDS happened on the 5th of March. And it mandated that every electronic health record system will have an interoperability and an audit component. And you would know who accessed the data, and you would be able to access the data in the format. And the deadlines are really, really tight. This is out of space. Here is the timeline. The publication was in 2025, and by March 27, we have patient summaries and e-prescription implemented everywhere. And by March 2031, we have all the priority data categories. And the same holds also for the secondary use of data, including the data quality requirements for primary use. So what is happening? How do we support? How do we provide policy support? And in fact, there are several initiatives that provide policy support. They provide policy support for governance, like the HDAP community of practice, and they have network, and they have stakeholders group. The first two will become the FDS board, which will govern the European health data space. And the third one will be like a stakeholder forum, as it is today. Now, in terms of primary use, there are 3 projects at least. There's a joint action where member states are participating, called XDHR, which will be developing implementation guide and technical specifications. And XAIR, the project I described, which will be actually giving us the sample and testing the specifications that are co-developed with XDHR. And finally, Expand the Edge, which prepared the ground and finished in December. On the secondary use side, we have the Quantum project, which develops a quality framework, a quality labeling and utility framework for secondary use of data. We have TEDAS2 with its guidelines to gain a joint action among member states. And finally, the Health Data EU pilot, which was just completed at the end of 2024, which is about showing what you can do. Now, the key thing that I would like to share with you in the next 2 or 3 remaining minutes is how do we go and implement this capability that every healthcare system would allow patients to get their data. And in the paper that I quoted earlier, we have explored 3 different policy options. And you see in the slide in front of you, the first one. The first one is decentralized. And actually, this is my favorite one. Any healthcare system that has a patient face should provide data to the patients. You click the XR button, you get your data. And it is important, it has significant advantages that wherever you go, whichever healthcare facility, you get access to your data in a computable format, you put it in a vault and you get actionable insights. Of course, it has a kind of a high burden, and especially in less mature situations, it may be difficult to implement or very costly. But I think this is the ideal, especially if we are committed to implementing standards. The second option is another one, which is centralized. In this one, we say that each member state is providing a single platform where patients would go and get all their data. It remains the obligation of the member state to actually convene with the ecosystem and demand that the electronic health record vendors connect to the platform to provide access to patients to the data through the single central web portal or app. This can slow down things because maybe there are some countries that are more advanced, or maybe there are providers that want to provide superior service. But again, it's easier to manage when you have a very fragmented system in countries. And the last one is a hybrid model. And this model we have thought about in regional healthcare systems, where you have one country, but then regions are autonomous and they can implement the way they like. This offers a lot of flexibility and stepwise implementation, but at the same time requires coordination and you need some kind of consistency. So you need regular testing and certification. So these are our kind of thoughts there. And in our work, we reach out several recommendations. The first recommendation is that we need to have more guidance on how to implement the HealthDS regulation. Second is that we need to align the national strategies and communications about the format and how the HealthDS will be implemented. And then there is a support center, so we need to have some standard support in the support center. Finally, we mentioned the XR yellow button specifications, which have been already implemented in some adoption sites. Maybe they could provide the basis for a European-wide eHealthDS readiness assessment. Stakeholder engagement, that's important. And especially when we are talking about electronic health record systems, we need to make sure that we differentiate between product classes and use cases, because not all use cases are the same. We need to support manufacturers and healthcare providers with contextual guidance and funding. And some of the testing and labeling experience that we have done in XR may be transferable in the plans of the European Commission. So just to conclude, our vision in XR is that everyone can effortlessly share their health data in the European Electronic Health Record Exchange format with a click of a button. We have developed a button and a label. We are basing our work on the data portability of GDPR, but at the same time, we are working within the context of the HealthDS, and we are supporting the Digital Compass 2013, which allows for a vision of human-centered sustainable future. There are benefits to sharing, and definitely strengthens digital resilience and advances the role of Europe globally in terms of digital health standards. But to make this happen, you need to be able to create a golden bridge from the intention, from the actual government and governance to implementation, to the practice, because that's where things happen.
Thank you so much, Katerina. We are a little bit stretched for time now for the discussions, but I ask for a round of applause. I think it was an interesting conversation we have here. We are going now to split rooms, Padma, so please shut us down here, because we are going to have a different discussion than you in our Zoom room with until the next 10 minutes. We have here 10 minutes to talk. But before we go, I have here a special thanks to give to a person that is in the room from DCHW. Kate Hughes is a person that from the start helped us a lot to support, to create these moments, including inputs on the initial agenda. I think I would kindly ask a round of applause for Kate Hughes, who is leaving. Thank you so much, Kate. Unfortunately, she's leaving the HCW, so, but hopefully... Okay.
That wasn't my resignation.
Okay, okay. So let's do 10 minutes conversation to wrap up all these, right? Because we talk about implementation, we talk about so many things, and we need to take some notes. So I would propose, for instance, the four of you to come here, please. 10 minutes talking here with Rafael. He does not speak English fluently, but I'm sure you'll get some help. Please come here. Maybe Finn, if you'll be so kind, and Hannah to join this table here. And maybe Ian, yeah, if you two come here, there are 3 years. And 10 minutes to wrap up all these and try to see what sense can we make of this, because lots of talk, implementation. What is it that we really need to put in our charter, in our joint charter? What is it that we need to add from this wonderful conversation so far? So we need to have at least one input per table. One input per table. So yes, okay, Finn. So you have access to the document. You can take the lead here. in representation of Sarah McCarthy, which cannot attend, the CEO of Social Care Wales. It's an important part of the element of the ecosystem in this beautiful nation. And it's a pleasure to have Social Care Wales here and the summit represented by Lisa. I'm sure you're going to enjoy the conversation we are going to have here with Andrew Roddam, which is just finishing the parallel session that we are having in a virtual world. So I take advantage here. Lisa is going to be listening to your comments also, perhaps incorporating them in the conversations that are going to follow. Is that okay, Lisa? I'm taking you a little bit out of the box because you probably were expecting something from this summit, but this is a space of dialogue above all, right? But obviously the goal of having this last fireside chat is to integrate everything in a broader perspective, bringing social care, and we are going to see a video, right? I'm unveiling a little bit what's prepared, so you're going to enjoy it, I'm sure, these last 30 minutes, and at 5:30 we finish. So before that, maybe we can have one or two inputs per table from the discussion so far. Which table wants to start first? Okay, let's start here.
Clearly we're short of time, but maybe because our speakers ran over, sorry. One thing we talked about here was the concept of a data promise, which might go by different words. We talked about similar things in different parts of the UK, I think, and what a data promise would be, which would explain clearly to our public what we will do with certain types of data and what we won't do. I'd be much clearer about it. It actually tallies quite well with our use my data mantra, which is say what you do what you say. So that was the prime thing we were talking about, a clear, concise statement to the public about what does and doesn't happen with types of data.
Thank you all participants for your conversations and for your inputs. Who is going to be here next?
I think for us it was
So,
very...
lady? Yes,
Go? Oh, I can go, perfect. Now, I was going to say that I think it also builds up what we said in the yesterday session as well with patient literacy and everything else, and it's building trust and relationships with everyone from day one also until the final follow-up as well. So whether you are, doing a contract bid and you're trying to go through the assessment, it's also understanding that your assessment of whatever you're providing is also evaluated after that contract goes through to ensure that you get best value for money and you're doing what you say, and that those who are meant to be, utilising your services actually do so. And it's a constant trust-building exercise, so to speak. I think also when we talked about it was also if you involve patients and those who are the end users early enough, all the problems that you normally get when it comes to when you're doing your clinical trials or anything else, it's already sorted out or it's already been flagged, and it's a lot easier to amend it before you've started a very expensive clinical trial, or if you're providing meals to a care home. If people don't like the food, it's a lot easier to do it before they've done their first order than it is when they're already eating the food or they've got a 6-month supply, something along those lines. So I think that's also what's needed as well.
Thank you so much. Thank you, participants. Last group, but not least.
Yeah, so we were talking similar about trust. We were talking about patient voice and how it was nice to hear that and how that should be thought of, right back in the beginning, as you said. And also we were mainly talking about standards and the importance, technical and data standards that were covered a few times in the talk today around SNOMED CT and HL7. So yeah, I think that was about it. Yep. Thank you.
Thank you so much. So a round of applause for this World Cafe Conversations. I think you're accomplishing a lot in debriefing all these presentations and thoughtful. Okay, so I already presented Lisa, but Andrew, maybe you could now start lead, and session is all yours. Sorry, and you don't need to pass the microphone. You have each one yours.
All right, so I think you've already heard me say a little bit about SNOMED and my side role, but just to kind of fill in some of the gaps, I trained in statistics. Okay, I didn't learn how to use microphones because you never had to. generally when I lectured, people just listened or fell asleep. It was a normal thing for a student in a university. I was an academic in Oxford for the best part of 10, 15 years, doing a whole load of population health and public health epidemiology. I've worked in industry for both Amgen and GSK and ran their epi real world, both for Amgen in Europe, GSK globally, so I've had teams spanning kind of San Francisco all the way through to Tokyo as we kind of brought together things for regulators, so anything was post-approval. I've had some of the weirdest questions you will ever get asked by a regulator, including on, which is pertinent as of what was happening in the US yesterday, on the safety of paracetamol and paracetamol dosing, because GSK, much beknownst to me when I first joined, is the world's largest manufacturer of branded paracetamol. In Panadol. It's now diversified into Halcyon, so we didn't actually have that piece any longer. Ran Our Future Health, so set up an infrastructure where we built out during COVID the ability to take blood samples from between 1,500 to 2,000 people per day at remote clinic sites around the country through a partnership with Boots, through trucks in car parks, through the blood transfusion service in England, Wales and Scotland, and also put in the whole infrastructure, and I now sit on the board of the sample repository for that, where we have the capacity to store 55 million tubes of bloods in fully robotic freezers and do robotic picking and sample storage. I also chair SNOMED, and in my day job I actually am the partnership business development officer for a tiny biotech which is trying to develop therapies for an individual person. So how do you take someone's genetic code, work out what the functional defect is which is causing the symptoms, and then develop an RNA-based therapy which will actually treat that child? And these are all pediatrics. They've got otherwise fatal conditions. Half of them probably won't get past age 5 to 10. The majority won't get into adulthood. And none of them have got an actual treatment that's available to them. So we have a partnership, and hopefully before Christmas, we'll start our first trial in Great Ormond Street and work from there. But working through what's the drug will always work. The challenge we have is the regulatory, the system, the reimbursement, the payment, the whole, everything else is a real challenge. Actually making the science is the easy bit for the first time ever in a sort of pharma project. It's normally always you have a molecule and you've no idea what it's going to do, even when you get out of the test tube. So that's what I do for a living. But as I said earlier, the passion that I have is about how we use data to the best possible way. And that's not just, you know, the health care data that we get at the end of it. And I think Lisa and I chatted briefly end of last week as the prep for this session. And, you know, what I'm really passionate about is very much what Lisa is. And, you know, we can kind of talk a little bit about that. But, you know, I've always characterised and campaigned from a policy perspective to the government is you should be able to access people's healthcare data. It informs a lot about drugs and vaccines and use and public and all those other good things. The reality, though, is that's the worst possible scenario anybody in their health is ever going to get to. If you've actually made it through the door and in front of a doctor, something serious has gone wrong with your health. It is not most of your health. So the fact that you've been hypertensive for 20 years and overweight and have high blood sugars and have all these other things going on, and you're not sleeping very well and you're struggling with a whole bunch of mental health issues, all of those things don't end up in those clinical notes that I get from the NHS. They only end up there when you've had a heart attack and you've been brought in A&E as a resus patient. They happen when I've dropped things on my hand and crushed bones or things that drop me into there. But also, they also only catch a very small episode of care. So for the work that we're doing on a daily basis, we want to know what happens if you treat a child who functionally can't really move very far, who can't feed themselves, who has 24 hours of care, who, for some of the children we treat, and I saw a referral last week for a potential patient that we're looking at, has between 30 to 100 seizures per day. That is not something you capture by looking in healthcare records. It's all of the other data that sits around that, and particularly the data sit around the parents, the carers, the other parts of the family that become an important part of what it is that you try to do. And that, I think, is really key to breaking down some of the silos that we have, the thinking about where standards play a role and how standards can bridge between health and social care and nursing care and other parts of those areas. Because only by understanding that true piece of the puzzle, which is what actually happens to you as an individual, will we actually make a whole lot more progress about understanding how interventions that work and how do those supportive interventions wrap around the absolutely essential part of giving clinical healthcare. But clinical healthcare is one small part of it. There's a whole bunch of everything else that goes around the edges, and we're not very good at doing a joined-up picture of those things.
Crikey, follow that. Andrew and I met last week and we had a very structured session, but I've sat here this afternoon and I just said to him, I'm going to go a bit rogue, so sorry about this. Can I ask just how many of you have worked in social care or with social care data? A little bit, some, kind of. Okay, and how many of you from the UK, or work in the UK rather, not from the UK? How many are from other countries? Okay, a few. Okay, so social care in other countries tends to be called long-term care, so just to get that one out of the way, tends to be. So one of the things that I thought is that given it's a very health data focused session, I might bring some social care. So we talking about the social determinants of health and some broader issues around equity and governance, but I'm going to do a crash course if that's all right, Andrew. So as Paul said, I'm from Social Care Wales. We do three things in Wales. We register social workers and social care workers, we develop the workforce, but we also support improvement across social care. And one of the reasons why I'm involved with Becca and Digital Health and Care Wales and the National Data Resource Programme is that part of our mission is to support the improvement of social care, and data is such a massive part of bringing evidence to the system and helping create more seamless care across the system. So I'm going to really abuse my 10-minute slot here, and I'm actually going to show you a video of what is social care, because I will never ever miss the opportunity when I've got health people in the room to do a bit of a thing on social care, but also because often we are fighting against, that's a little bit strong, we are trying to challenge the idea that social care is just a way of keeping people out of hospital. It can be it can be construed as, particularly for those of you in the UK will have heard the expression delayed discharges, delayed transfers of care, and horribly bed blocking. And the reason for that happening is always given as social care, which is simply not true. So I'm going to show you a very short 2-minute video on social care. I think it builds a nice picture, and then talk a little bit about what that means for data. So can I roll? Is that what they say?
Access care and support for various reasons. It could be to get support to establish safe and stable environments, to manage their physical and mental health, or to live independently. Unpaid carers who provide care and support to family members or friends can also access social care. The term social care covers a range of activities such as practical and emotional support, providing information, advice and equipment, safeguarding, and personal care. Social care can take place in a range of settings, including people's homes, care homes, day centres, hospitals, or in other community locations. It's provided by organisations including local authorities, private companies, charities, and not-for-profit organisations. A significant amount of care is also provided by unpaid carers. Tens of thousands of highly skilled, well-qualified professionals work in social care in more than 75 roles. Most social care workers in Wales must register with Social Care Wales and follow codes of professional practice. The codes set standards of behaviour to support people's safety and well-being. Social care workers support people to express what's important to them and set goals by building meaningful relationships that value people's experiences, language, and culture. They support people to identify and make the most of their personal strengths, skills, and support networks, including family, friends, and resources in their local community. They work with people in crisis situations and over the longer term. Social care organisations work with other professions such as health, education and the police to provide services with integrity, empathy and expertise.
A social care worker to me would be amazing, fantastic and caring and help me live a normal life.
To find out more about social care, visit socialcare.wales. Want a career in care? Visit wecare.wales.
I'll let Alison know that she got a round of applause. She'd be very proud. So the reason I showed that is because, we get involved with data projects, particularly in Wales, a project called the National Data Resource, which is about pooling health and social care data, and some other data projects. But I think sometimes it's easy to overlook some of the particular challenges around using data in social care when you're looking at it from a health perspective. So I thought I'd just do 2 or 3 things that are a little bit different, just while I'm here. So first thing is that in every country, the social care or long-term care system is propped up by millions of unpaid carers. And what that means for the care system from a data perspective is that we don't know how much need there is anywhere, because family carers will always step in. So we have an immediate issue, which is you can't measure demand. It's almost impossible. So that's quite different from the healthcare system, where you get some measure of waiting lists or waiting times. So that's one important thing. The other thing is that the type of funding that the system has a massive impact on how you collect data. So you'll find in the US, for example, where Medicare and Medicaid fund a lot of long-term residential care, that because of the insurance systems, they collect a whole range of routine data around conditions and around what providers are actually doing in practice. So you have a huge, probably the US is the only country in the world that has the level of data it has about nursing homes, but even there struggles with things like home care because it's so fragmented. But in every country, whether it's funded by the state or by individuals, you'll find a massively fragmented provision, and often, almost always, a huge amount of private sector provision. So how do you collect that data when essentially people are in a competitive market environment? That was another one. And finally, because I have gone completely rogue, Andrew, is outcomes. So you'll see from that video, one of the reasons I love that video and why we developed it is that something that is very important to remember about social care is the range of outcomes. It's about autonomy, about having a meaningful life, about being safe. So it's very, you'll have, those of you who've thought about value-based healthcare and patient-related outcomes measures and experience measures, you'll have had a bit of an insight into what it's like to collect data in social care. So, there have been some incredibly good efforts, like the Adult Social Care Outcomes Toolkit in England, which is used by the Department of Health and Social Care to measure outcomes across the system. There have been some really good attempts to develop psychometric tools to measure outcomes in social care, but gathering that data is still incredibly expensive and difficult. So I couldn't resist, having sat here this afternoon, to say some stuff about social care, just to get that conversation going. And I suppose, even though we are very keen to stress it's not about keeping people out of hospital, it is upstream, isn't it, Andrew, from what you described? So we talked a lot on the phone about Marmot's social determinants of health and how do you measure things much earlier in the system, and about the importance of education and public health and housing and all those things. Social care is on the spectrum, closer to healthcare than those, but is also an important part of supporting people to live independently. So Andrew, back to you.
No, I think you made
That's
some
not what
really
you
good points.
expected.
Because that, there's just a continuum, and I think that's the big thing, that you kind of, if you start to think about what the NHS is trying to tackle at the moment, which is ridiculous amounts of waiting lists. Aging population dynamics are kind of creating a sort of slurry of differing problems. There's a bunch of therapeutics which is sort of working reasonably well, which are then creating a whole bunch of different problems because you kind of get people with different diseases turning up at different times. And you can try and fix that by trying to fix the health parts of the system, and you can make hospitals operate 24 hours a day and kind of try and solve it that way. Or you kind of pull backwards a little bit and kind of go, well, actually, if you look across the country, health as a concept is massively disparate between areas of the country. You can go, walk across. I grew up in the northeast of England. I can walk between Sunderland and Newcastle, and I can go from life expectancies of 50 to 60 to 70 all the way through to life expectancies of 80 to 90. Now, that is not because I chose to live in one particular area. It is everything that kind of comes together in there, which is accessibility, inequality, the sort of population dynamic and structure, and sometimes genetic heritage as well, because of pockets of culture which live in certain areas of the country or certain areas of towns. And I think that's the importance. There's so many elements that we just don't collect the data on, and we can't plan the services appropriately. And we ridiculously spend all of our time thinking about how do we make the hospitals more efficient, or how do we drive efficiency, and don't get me wrong, I do not believe the NHS is yet in a massively efficient state, but I'm not sure we're going to get a big sort of return on our investment by putting all of our focus there without actually trying to tackle some of these upstream challenges about how you manage inequity, access to care, access to service, access to the educational things that they need. And we know there are so many barriers, and I always use the classic example of people who smoke. Not many people who smoke will actually argue with you that smoking is a good and healthy thing to do, and it has no health effects whatsoever, and it's perfect. People find it incredibly difficult to give up, no matter whatever intervention that you place on them. Behavioural change is one of the hardest things you ever try to do, and it's driven by population characteristics and the societal impact around the individual as to whether you're willing to do that. Everything upstream of getting ill is all about behaviour change just to kind of get you there. And that can be getting you out of poverty, it can be bringing you access to education at the right time and in a way that is accessible to you. It's about providing the right mental health support in the community to address the challenges that you are facing. And it's about understanding and recognising all of those. And that's the system upstream of everything that we do. And, as I said, we're spending a lot of time at the last point of care. We're not really putting the effort into sort of thinking about how do we measure some of that stuff? How do we bring it together? And how do we actually ultimately inform policy decisions at the end of it to sort of, and long-term policy decisions, because these governments hate it, because they're not going to see an impact of changing obesity in a 5-year window. That's not going to change the number of heart attacks coming through the door. It's not going to change the number of strokes. You're going to see the same numbers coming through. In 10 years, you might start to see a bit of an impact. But governments only have a 5-year window at best. Most of them only have about 2 years by the time they've twiddled around for a little bit, done something, measured something, and then they're campaigning for the next election. So the cycle doesn't play itself to long-term policy structure. And everybody has their own view of healthcare and social care, and whether you're conservative, liberal, whatever, they all will do something slightly different. So it's really hard to get policy consistency as well.
One of the things that Andrew and I talked about as well last week is once you're in the health system and once you're experiencing clinical interventions is the lack of focus by researchers into broader outcomes. So we both shared some examples. I sit on the appraisal panel for our local health technology assessment body, Health Technology Wales. And I remember some time ago we had a intervention which was to test pregnant women to give them continuous blood glucose monitoring if they were likely to develop gestational diabetes. And all of the research was around how long premature babies would be in hospital if their mothers developed diabetes. And so there were two outcome measures. There's one outcome measure is the length of time in neonatal intensive care. And as Andrew and I were talking, and one of the really difficult conversations and frustrating conversations that we had as part of that discussion is the lack of information on the societal cost of having a baby in neonatal intensive care. So, it's the cost to the NHS. But actually, if any of you have had own children in neonatal intensive care, NICU, or if you've known people who do, you'll know that it comes with a tremendous cost to families, whether it be just parents having to travel to the hospital every day, the emotional cost of being without their child, the mental health cost, the cost of giving up work if it's a prolonged stay. And so a lot of the research that we fund and deliver doesn't actually think about these, even with the sort of the ecosystem of health, they don't think about anything other than the impact on the health system. So we had quite an interesting, and you had your own personal experience of this recently.
Because earlier this year I became quite unique. I had multiple tears in my retina, which were all laserplexed 1 week. Went back for a checkup, and the consultant was like, "Oh, there's a little one just there. We'll just laser it again." Turned out lasering it again meant that it was a full-on detachment, and I was put on the clinical emergency list for that afternoon to have the middle of my eyeball sucked out, the cryoplexy put into the back of the retina to stick the retina back together.
Sorry, everyone.
It all up. And then having the gas bubble that gets inserted into your eye to act essentially as a plaster to stick the retina back to the surface to help it happen. Now, if you read my clinical notes in the NHS, it says patient had a MAC-on retinal detachment which was replaced by cryoplexy, discharged to home to care, normal recovery. What it fails to capture is that for 5 days, I was as miserable as sin at home and probably annoyed the hell out of my kids and my wife, because I had to lie still on one side of my body and could only move for 5 minutes in every 30, because the bubble has to press against the bit of the eye that is detached, which for me was the upper left corner, so I was just laid like that, getting bored. Language subtitle movies, which were not so good if one of your eyes isn't working and you've got a big black thing sitting in front of it. Then the 2 weeks while you still have a bubble and you have no depth perception while you're walking. So at lunchtime, as I went for a walk around the village because I could move, I looked like some drunken person who'd been out drinking at 10 in the morning because I was stumbling off the edge of the curb because I couldn't quite work out where it was relative to my feet. And all of that is sort of trivial, but it's not captured when you actually work out the sort of total cost of care or the total impact of an injury. And even today, I actually don't have perfect vision. I've got to go back because I rapidly developed a cataract almost immediately after the gas bubble injection. It stimulates cataract production relatively quickly. I've got to go back and have that taken out next. And like night times, any bright light, I get shining halos around one eye. Only one of them really works. And all of those things, irritating and annoying, but they're just not captured in the sort of system of when we say somebody had this one procedure, it took 3 hours in the afternoon, they're all done and gone, and they're out of the hospital and they've had their one checkup, and that's all they actually need. When everything else of the impact on you as an individual, and that's true for pretty much everything that you think about in healthcare.
And, I was really struck as well, Kerry, when you were talking earlier. Kerry just shuddered. Sorry, I hadn't never seen anyone do that before, Kerry. One of the things that is also a consistent theme with some of these questions around, if you just go back to social care and health care, is we have very big conversations about data promises and about transparency in patient data and public data. One thing that is very difficult to think through, and I think an organisation, One London in London, has done some of this work really well, is to really think about what we mean by having data sharing between systems. What do we really mean? I may be very happy for people to know, for my housing association to know that I've had home care support and that I'm under a consultant for orthopaedic care. But I may be absolutely horrified to find out that, say, my mental health records were shared, or my gynecology records, or having been in an abusive relationship, or having a criminal record. So, I think can have some of these very big, important conversations. But I think one of the challenges for us as people interested in evidence and data is about actually doing the hard yards of asking, what are your red lines? You know, I don't want you to share my mental data. What if that could mean that we could do really good research into your condition and we might be able to give you some support? Oh, okay, well, if I don't know who I am, that could be really, so it's these red lines and important decisions and bringing those questions, I think, to some of this discussion, rather than, it's the governance structures are absolutely vital. The structure of how we support transparency and governance is clearly essential, but it's the devil in the detail that I think we all need to really kind of think through.
And I think if you go historically, we've worked in a world where aggregated, pseudo, whatever you want to call it, in legal terms, but de-identified data became the norm for sort of research. And there's a lot of thinking. I support and advise about 2 or 3 different startups have been trying to think about this, the sort of concept of putting the patient, which is not really the patient, but the person or the human being at the center of owning/controlling, so it's not clear whether it's ownership or control or management or permissioning their data about themselves and how they want that data to be used. And it's one of those horrible things that's really, really simple for me just to say that, the actual practicality of making that a reality. So that how many times do you want to be contacted? What if your data is used 1,000 times a day? Do you really want to be asked 1,000 times a day? What if you give too much consent and blankets, and how would you bring it backwards? And I do think the world is going to a place where we think a lot more about, I think in the world of ethics, it's the sort of dynamic consenting models that exist. Because we've got to be able to allow the sort of sharing happening, but to allow it to be used in a way that we can each control how we want that data to be shared and for what purposes. Because when you understand that, you become much more comfortable with how it's actually going out there. Whereas, whilst we are all happy to give Tesco, Asda, Sainsbury's, whoever, all of your shopping information, and most of you don't know how informative that is about you as an individual, given how much Tesco's actually make every year from selling that data on sort of shopping trends and patterns and habits. We're not willing to share health data in that way, and equally our criminal records or our tax records or our employment history or our social benefit claims, all of which are incredibly powerful in understanding about you as an individual. But putting much more control onto that is going to be a feature, I think, as we move forward, to not just massively create mass data sets where everything's in one place, but that we've all got levels of control that we're comfortable with about how that sharing actually can happen.
One of my great pleasures in life is being asked to use my club card. I don't know if any of you, I'm sure most of you have Tesco club cards, and you will have been in the situation where someone says, I haven't got my club card with me, have someone got one so I can get the discount? I love that, because suddenly they think I've got a dog, which I don't, or I drink really cheap lager, which I don't. So I love messing with Tesco data, so I'm usually there putting my hand up. If you don't live in the UK, you'll have no idea what I just said.
Well, the Amazon parallel is my wife's manages a publishing list for one of the big publishing houses, and she used to manage the series of books called Teach Yourself, which largely have a language section, but they also have a non-language sort of section. She managed the non-one. The messing up that she can do of an Amazon algorithm over what book you should read next. When I think there was one year she was doing Teach Yourself wine tasting, Teach Yourself how to play golf, Teach Yourself relaxation, Teach Yourself great sex, and Teach Yourself basketball. The algorithm that Amazon then suggests to you that the next book that you should read of all of those combined together becomes a really interesting sort of proposition, which my kids ask many, many questions of whenever they look at her sort of, I think you should be reading, Mum, what have you been reading?
So I think we did the rambling conversation we planned, didn't we? I think, we did say we'll just freestyle it, and we had a list of bullet points. So I think we covered 1 or 2 of them. I think that's victory.
I think that was about right.
Yeah. So I think, Paul, these people have had a long day.
a lot.
Consegue me ouvir?
Thank you so much, everybody, for this wonderful day. I think we have an extremely intense day. From the start to the end, every moment, every minute, even better than the past. So thank you so much for closing this like this. Thank you. Okay, so I'll see you all tomorrow here at 8:30. So we're going to have an early start in order to finish at 1 o'clock. Can you expect tomorrow we're going to have even better sessions as we are improving every time. Trusted research environments and other interesting in cybersecurity. So we're going to have a practical case introduced by David Witham Lewis. So it's going to be a great day and compact until 1 o'clock. I would kindly ask the person in this table who took notes, so if you can approach me, so we exchange emails and share you the shared document, if that's okay. Yeah. You didn't take notes? Oh, that you... David? Okay, yeah. So, but David has already access to the document. Okay. Thanks. Thank you all, our World Cafe participants, for your contributions as the dialogue proceeds. For the guest speakers, don't forget guest speakers 7:30 in this lobby. 7:30.